those terms interchangeably. You'll hear me say 1 minute epilepsy, the next minute I'll say seizure disorder, because in fact, for all intents and purposes, they are the same. Okay, so don't let that confuse you. In fact, if at any point during this I do become confusing, that's probably going to happen. What I would ask you to do is to please don't hesitate to say, "Hey Tom, I'm not sure what you're trying to say here. Can you explain that differently?" Certainly, that would be no problem at all. And we are going to try to take some time at the end of this particular presentation for any questions or comments you might have. But if it's a really burning type of question, please ask it while you remember it. Okay. There we go. I have a variety of goals in mind for today's presentation. My first goal is just to provide you some information about seizures and epilepsy. My second goal is to help you to better recognize different types of seizure activity. Seizures can take many, many different forms. Seizures can be very, very dramatic events, something that it's really difficult to forget once you do witness one. Other types of seizure activity can be so fleeting that the person sitting right next to you at this point in time could have one and you may not realize it. So they run the gamut from being sort of showstoppers to being something that you may not even realize took place. So we're going to talk a little bit about the very, very dramatic types of seizure activity and also about some of the more subtle types of events. It doesn't do you a whole lot of good to be able to recognize that somebody is having seizure activity if you're not certain what to do for that particular event. So we're going to spend a little bit of time talking about how to handle a seizure if, in fact, it does take place. I also would like to be able to provide you some information that's going to help you to provide supportive, positive treatment outcomes for an individual who has epilepsy or a seizure disorder. And also, finally, to provide a supportive environment for those with epilepsy. And my final comment is, I realize I'm right before lunch, so we'll try to get done on time, okay? Okay, in order to begin to talk about epilepsy, the first thing that we need to do is we need to spend a little bit of time talking about the crux of the matter, a seizure. A seizure is a brief interruption in the usual way that your brain functions. That brief interruption takes the form of a release of electrical energy from your brain. That release of electrical energy may cause a loss of consciousness. There might be a change in the person's consciousness. There may be an involuntary movement, a muscle spasm, or even a full-blown convulsion. At this particular point in time, there are over 30 different types of seizure activity. So seizures run the gamut. Having a seizure does not necessarily mean that you have epilepsy. What we know is that 1 out of every 10 individuals in the United States will have an isolated seizure at some point in their life. So every one of us is going to know probably more than one person in our lives who's going to have seizure activity. So seizures are very, very common events. This release of electrical energy and its outward manifestations are what we call a seizure, and it can happen at any time in a person's life. There is no specific date in a person's life that seizures cannot occur. So they can run from birth all the way up to senior citizenhood. Okay, a definition of epilepsy. Epilepsy is defined as a neurological disorder or a disease characterized by recurrent seizures. So in order to be diagnosed as having epilepsy, your first criteria is that you have to have had more than one seizure. Or you have to have a very high probability of having additional seizure activity. That's the first that's the first criteria. The second criteria is that the seizures have to reoccur over time without any type of precipitating cause. So for an individual to be diagnosed as having epilepsy, there has to be no direct causal factor for that seizure to take place. For example, sometimes young children will have what we refer to as febrile seizures. Febrile seizures are not epilepsy because the fever is what is directly impacting the child and causing the seizure activity to take place. Okay, incidence rates. Many people have epilepsy. Our incidence rates run from about 2 million to 3 million Americans. I chose the higher figure. 3 million Americans are currently diagnosed with epilepsy. It often strikes among the young and the very old, but it can develop at any age. 326,000 children 15 and under are affected. 90,000 of those children have what we would term severe seizures. We have 570,000 adults age 65 and older who are actually diagnosed with epilepsy. So we see it usually occurring on either side of the age spectrum, to very young individuals and to older individuals. I want to spend a little bit of time talking about the causes of symptomatic seizures. These are some of the causes: birth defects, difficult birth, lack of oxygen, stroke, infection to the brain, brain lining, brain lesions, poisoning, genetic influences, high fever, or traumatic brain injuries. Those are some of the things that can trigger a seizure in an individual. Moving on to the causes of epilepsy, for the large majority of the people who are diagnosed with epilepsy, the cause cannot be determined. And about 70% of those individuals who have epilepsy, they have what we refer to as idiopathic epilepsy, epilepsy without a determined cause. So oftentimes an individual is not told exactly what causes their epilepsy. And the remainder, which is at 30%, they're generally the same as for symptomatic seizures. I do want to begin to talk about the classification of different types of seizures. And the classification system that we are going to use today is the one that is supported by the International League Against Epilepsy. The International League Against Epilepsy is individuals who are primarily physicians or researchers in the field of neurology or in epilepsy itself. And what we found is that over the years, there are many different ways to describe the same type of epileptic event. For example, I could say that my son has major motor seizures, or that my son has grand mal seizures, or that my son has generalized tonic-clonic seizures. And you might initially think, my gosh, he has 3 types of seizure activity? No. There's 3 ways of describing that same event. So what the International League Against Epilepsy decided is that we want to try to codify the classification system so that we all realize what we're talking about, so it's easier for us to communicate with each other. And in doing this, what they did is they decided to divide seizures into 2 basic groups. The first group that they divided it in is generalized seizures. When a person has a generalized seizure, the first rule of thumb is that the seizure involves the entire brain. So that release of electrical energy that is a seizure swamps the entire brain from the onset. The second rule of thumb regarding a generalized seizure is that the individual usually becomes completely unconscious during the event. So if your loved one becomes completely unconscious during their seizure activity, you know that it's generalized in nature. The second type of classification that we classify seizures under is partial or focal seizures. These particular types of seizures involve only a specific area of the brain. The area of the brain involved in the seizure activity will determine what takes place during the event. Also, with partial seizures, there may be no loss of consciousness, or there may be an alteration in the individual's consciousness, but a certain level of consciousness is preserved during a partial seizure. We're going to begin our discussion of seizures actually talking about some of the common generalized types of seizure activity. Well, no, we're not. We're going to talk about spectrum of severity. When we talk about an individual's seizure activity, we usually try to classify it as far as the severity of the particular event. 50% of the people who have epilepsy have complete control over their seizure activity. That means that basically they may go years and years and years without having any type of seizures, and epilepsy does not seem to have a very large impact upon their life, other than to remember to periodically go to their physician and to remember to take their medication on a daily or maybe a more frequent basis. We've got another 25% who might be compromised by their epilepsy. For those individuals, they might have side effects because of their medication. Still, they have very good control of their seizures, and it doesn't seem to have a major impact upon their ability to lead what we would consider a normal existence. We have a third group of individuals who are devastated by their epilepsy. This comprises about 25%, and these individuals tend to have seizures on a very, very regular basis, maybe several times a day. For these folks, what we find is that their life is pretty much devastated by their epilepsy, that they're unable to lead a life that most of us would consider normal. Most of the people that I see actually fall into that devastated group. Okay, now we're going to begin to talk about different types of seizures. And the first type of seizure we're going to talk about is known as the tonic-clonic or grand mal seizure. Basically, when a person has a tonic-clonic or a grand mal seizure, the first thing that happens is there's a loss of consciousness. So if the individual is standing, they're going to fall. If they're sitting in a chair, they're usually going to slump to one side or the other. The next phase is the rigidity, or the tonic phase. Tonic refers to unrelenting muscle rigidity. So for about maybe 15 to 30 seconds, quite literally, the individual becomes as stiff as a board. Following this, they will transition into the clonic or the convulsive part of this type of event. This convulsive part will involve all the muscles within the person's body. Usually we will see some shallow breathing that will occur. There will also be some drooling or a release of saliva into the individual's mouth during this tonic-clonic event. That's where one of our first problems comes into play. For an individual who has epilepsy and is experiencing a tonic-clonic seizure, we need to position the individual properly, or they're not going to be able to breathe during their seizure, or they may actually end up aspirating some saliva actually into their lungs at the end of their seizure activity. So we want to make sure that we turn the individual over onto their side as soon as we possibly can during their tonic-clonic event. Usually this particular type of seizure will last no longer than 1 to 3 minutes in duration. That is, unless I happen to be there, because I have never personally witnessed a tonic-clonic seizure that did not last an eternity. Or at least it felt like it was lasting an eternity. So this is where our second thing that we need to do for the individual comes into play. You need to make sure that you time the seizure activity. That's going to determine what other steps you have to make. Also, if you do need to call the EMTs, one of the first questions they are going to ask you when they arrive is, how long has this been going on? So we need to have an accurate idea of how long the seizure activity has taken place. There will be usually some skin bluing or ashing. You'll certainly witness that around the lips or even in the nail beds. There might be a possible loss of bladder or bowel control. That happens at the end of the seizure activity. So in one way, it's a bad thing. In another way, it's kind of a good thing because it is a signal that the seizure has come to a stop. Now, following this tonic-clonic or grand mal seizure, what we will notice is that the person who has experienced it will be confused. They're confused because they don't remember anything that took place during the event. Also, the individual is usually tired. They've used a lot of energy. So it's not uncommon for the individual to go from this very dramatic, very active state into a deep sleep, the kind of sleep that you have to actually rouse them out of. I would encourage you to rouse the individual and get some kind of a response. If you're getting a response, you know the seizure has come to a stop. Also, we might see some emotional upset. An individual after a tonic-clonic seizure may be angry, they may be upset, they may be embarrassed that the seizure activity has taken place. These three things, this confusion, this tiredness, this emotional upset, we have a special name for it. We refer to it as the post-ictal phase. Ictal is just another word for seizure. Post meaning, of course, afterwards. Now, the seizure itself is usually relatively short. The post-ictal involvement can go on for hours. But the good news about folks who have seizures is that most of them develop what we call a seizure pattern. They tend to do the same things every time they have a seizure, which makes our job in caring for those individuals a little bit easier, because it can become a very predictable type of event, knowing how long the seizure is going to last, knowing how long it's going to take for the individual to recover and be back to their usual self after they've had a tonic-clonic or grand mal seizure. I want to move on to talk about another type of seizure. This one is on the other end of the spectrum. When a person has a tonic-clonic seizure, you usually know that there is something that is definitely going on with that individual. With an absence seizure, you can miss this event completely. The absence seizure involves a pause in activity with a blank stare. This particular type of seizure, some of the things that we might see, some of the characteristics of this seizure activity are maybe repeated blinking of the eyelids. There might be some eye rolling. There might be some very slight facial tics. And there is always this blank expression and blank stare that accompanies this type of seizure activity. It is also accompanied by a brief lapse of awareness. So it's as if the individual experiences a brief little blackout with an absence or petit mal seizure. This type of seizure activity usually lasts no longer than maybe 5 to 10 seconds in duration, so it's very, very short. So if you're actually not focused on the individual, you may not realize that this event has even taken place. It will sometimes occur in a series, so you might see somebody who has maybe 10 or 15 of these within the course of a very short period of time. And it is possible for individuals actually to have up to 300 of these events within the course of 24 hours. So it can be very disruptive to the individual's ability to concentrate and also their ability to learn. It is sometimes mistaken for other types of behavioral problems, such as inattention, daydreaming, or even attention deficit disorder. So sometimes children are misdiagnosed as far as this absence or petit mal seizure. The good news about this particular type of seizure is very rarely does it involve any fall with an absence or petit mal seizure. So there might be a slight maybe change in the person's muscle tone, but the person usually remains upright and they just stop what they are doing. They just come to a halt for 5 to 10 seconds and then they're back with you. This type of seizure activity usually is 99.8% happening among young children. So we don't see this much in adults. Adult onset is very, very rare for absence or petit mal seizures. Let's move on to talk about atonics. Atonic is a type of seizure activity that's also known as a drop seizure. There's the word tonic. Tonic is, you may remember, is muscle rigidity. When you put an A in front of a word, you mean the absence thereof. So we have the absence of muscle rigidity. So what happens when a person has an atonic seizure is they experience a complete loss of consciousness, and along with that loss of consciousness, if they're standing, they're going to fall. If they're seated, they're going to very much slump. They're going to lose complete muscle tone with this type of seizure activity. This type of seizure, the atonic seizure, usually lasts no longer than seconds. There again is no recovery from it, so the person after it is over goes right back to what they were doing, much like the absence or petit mal seizure. So this type of seizure is can be a difficult type of seizure to deal with because there's no type of warning that these events are going to take place, and the person oftentimes can become injured due to these losses of consciousness and the fall that accompanies them. I want to move on to myoclonic or the myoclonic seizure is a brief, massive muscle jerk. The myoclonic seizure may or may not involve a loss of consciousness. We classify it as a generalized type of seizure activity, but not always do we see a loss of consciousness with this. This type of seizure, probably most of us in this room have had something very similar to it take place. Have you ever been laying there in bed and you're getting ready to fall asleep and suddenly your leg jerks or your arm jerks or your body jerks? That's called sleep myoclonus. It's not epilepsy, but it's very similar to what happens when a person has a myoclonic seizure, this brief, massive muscle jerk. These brief, massive muscle jerks might involve maybe an arm, a leg, or maybe even one side of the individual's body. They can occur many, many times within the course of a day. You can have a series of these particular jerks. It might cause you, maybe if you're at the cafeteria, to throw a tray in the air, or maybe fling a pen across the room. So these brief, massive muscle jerks. Juvenile myoclonic epilepsy is a type of it's an epilepsy syndrome that usually occurs right around puberty. So sometimes we'll see these particular types of seizure activity occur when an individual goes into puberty. I want to move on to talk about partial seizures. And as you remember at the beginning of this, I spoke of the fact that partial seizures involve either no loss of consciousness or an alteration or a change in the person's consciousness. Now, with simple partial seizures, there is no impairment of consciousness. The person remains aware during this particular type of seizure activity. And it might involve various involuntary movements. For example, there might be isolated twitching of maybe the arms, the leg, maybe the fingers. Some individuals might have twitching on the side of their face during a simple partial seizure. There might be sensory symptoms that are involved in this type of seizure activity, such as maybe a tingling on some area of the skin, maybe a sudden weakness, maybe the individual actually hears a sound that isn't there, maybe smells something that isn't there. They might have maybe a strange taste, such as a metallic taste in their mouth during a simple partial seizure. There might even be a visual distortion during this type of event. Some individuals might have psychic symptoms, such as a feeling of having been or done something before, maybe a very, very structured hallucination, maybe fear, anxiety, a feeling that they just can't explain. This type of seizure can and is actually diagnosed on the EEG, but due to the fact that the person does remain conscious during it, and that it's usually very short-lived, usually lasting less than a minute, that this type of seizure activity does not involve any type of first aid intervention. Sometimes people who have this type of seizure activity will have it confused with acting out, maybe a mystical experience, mental illness, or maybe even a psychosomatic illness. So the point of me bringing up simple partial seizures is that, in fact, that seizures aren't always what we usually think of them as being, that they can involve different types of sensory input without any loss of consciousness. Complex partial seizures. Complex partial seizures are seizures that, again, involve only one area of the brain. Usually we'll see complex partial seizures oftentimes in the frontal lobes or in the temporal lobe of the brain. This particular type of seizure involves an altered state of awareness. So the individual goes from their usual baseline awareness and becomes very impaired during a complex partial seizure. Usually one of the things we'll see during this type of seizure is a blank expression and a blank stare. Following that, we may see some automatism, such as an individual repeatedly picking at their clothes, maybe wringing their hands. They might pull at their hair during this particular type of seizure. There might be some lip smacking, some chewing motions. Individuals might have garbled speech or they might make guttural types of noises during this particular type of seizure activity. There might be clumsy or disoriented movements. Among individuals who are able to walk, occasionally what happens is they get up and they begin to move around during this type of event. This is where one of the major problems with a complex partial seizure comes into play. During this type of seizure, the individual is in that altered state of consciousness, so they may not realize that they're headed towards a stairwell or a busy intersection. So accidental injury can result from a complex partial seizure. During this type of seizure, the individual will not respond appropriately to anything that you say to them or anything that you ask them to do. They don't know who you are, and they don't know why you're trying to assist them. So don't expect any type of directions or instructions to be followed during this type of event. What we know is that if you intervene inappropriately during a complex partial seizure, you may end up getting hurt, or the individual may end up getting hurt. They do not know who you are. They don't know why you're trying to assist them. So if you grab an individual who is having a complex partial seizure, they will usually struggle against that restraint and want to be free in order to continue to move around. Usually this type of seizure lasts no more than 1 to 3 minutes in duration. That'll vary greatly from individual to individual. The neat thing is that that particular axiom that a person tends to develop a seizure pattern holds true for this particular type of seizure activity. So you tend to see the same set of complex behaviors during an individual's complex partial seizure. So you see the same types of behaviors every time they have them, or usually that tends to be the case. They're often followed by tiredness, headache, emotional upset, and also confusion. So again, with this type of seizure, as with the tonic-clonic, there is that post-ictal involvement afterwards. Usually this is rather short-lived for the complex partial seizure. It might be confused with other types of behaviors, such as maybe drug or alcohol intoxication, or even some types of mental health difficulties. So sometimes people misdiagnose this particular type of event. Okay. In talking and in dealing with somebody's epilepsy or their seizure disorder, what we like to do is we like to develop what we call a seizure action plan. A seizure action plan is a set of guidelines that we're going to follow when somebody has seizure activity. And you might be thinking, well, you know, I know how to do this. My wife knows how to handle my son or my daughter's seizure activity. We're pretty good with that. That's true. You may be pretty good with that. But there are other caregivers who may not be very good with that, or may even be frightened by the fact that you say, my son or my daughter has a seizure disorder or epilepsy. So what we ask you to do is develop a seizure action plan, not only for yourselves, not only for grandma and grandpa, but also for other caregivers who might be involved with this particular individual. And the first thing in a seizure action planning that we want to do is we want to assess the individual's needs and gather information. What type of seizure activity do they have? What are the usual signs that they're having seizure activity? When do we want to call for emergency assistance? Does the individual have rescue medication that is used at a specific period of time in order to stop their seizure activity? So those particular things are the information that we need to gather and that we need to have in a very understandable way available for not only relatives but also for caregivers. Then we need to customize that seizure action plan. We want to talk to our physician about this. Some physicians will say, you know, maybe, you know, what we want to do is we want to administer diastat or another rescue medication at the 3-minute mark. Another physician might tell you we want to do this at the 5-minute mark. But it varies from individual to individual. So we need to have those particular things okayed by the physician in order to make sure that we're going to be providing good care for our loved one. And finally, we need to teach our family, friends, and coworkers interventions and tailor those interventions as needed. Not talking about an individual's epilepsy doesn't do them any good. And it certainly doesn't do the acceptance of epilepsy or other medical conditions any good. I think we need to be open about it in order to ensure that our loved ones get the care that they need when they need it. By withholding information, we just make the situation that much worse for them. Statusepilepticus. Probably this wouldn't be complete if we didn't talk about this. Statusepilepticus is a nice Latin term for an unending seizure. It's medically defined as 30 minutes of uninterrupted seizure activity and may include one very long event, or it might include numerous events that are relatively short, but the person never gets back to baseline. So you might have one tonic-clonic seizure that lasts a relatively short period of time. It stops, you think, thank goodness this is over, and then the individual goes back into another tonic-clonic event. So Statusepilepticus, it is considered a medical emergency, and you need to talk to your physician about what constitutes status for your particular child so that you have that particular information available. And as you can see, every person's seizure action plan should clearly define what constitutes a seizure emergency and detail an emergency plan response. Usually, what we use as a general rule of thumb at the Epilepsy Foundation is that if a tonic-clonic seizure lasts for longer than 5 minutes in duration at that particular point in time, you should get emergency assistance for that individual. Or if they would have one seizure, it would stop and then have another tonic-clonic event. That would be another indicator that you need to get emergency assistance. Certainly, that can vary as your physician advises. My final bullet on this is something that I think is really, really important. Some individuals will go into seizure activity and there won't be a whole lot of movement that's taken place. In fact, you might actually think that the seizure has come to an end when, in fact, it is still taking place. So one of the ways that we tell whether or not a seizure is over is to get a response from the individual. A person who can respond to you in one way or another is out of seizure activity. So we need to get that response from the individual, either a shaking or some other type of response, so that we know that the seizure has come to an end. Don't assume just because that the movement has stopped that the seizure is over. There still might be neuronal firing that's taking place and still causing possible damage to the individual's brain, even though you're not seeing any outward signs that the seizure is taking place. I'm not sure where I am. Okay, we already talked about seizure first aid. And let me at this point ask, does anybody have any comments or any questions? Yes, please. Okay, what are the dangers of a person having continued seizure activity? Basically, what we know is that once you get past that 30-minute mark, that we're beginning to see a lot of death of brain cells. Okay, and that's taking place. Also, we can also, if the seizure continues to go on for a very, very long period of time, it can be either a life-altering situation where the individual's memory, their functionality is affected, or sometimes, you know, seizure activity can lead to death. Okay, so that's why that's why we think that it's so important for an individual either to be administered emergency medication or to be transported to a hospital at that 5-minute mark. Okay, so the longer seizure activity takes place, usually the greater the possibility of a negative outcome. The greater the possibility, the longer the seizure takes place, the more the possibility of a negative outcome. Okay, the greater the possibility of it. Yes, sir.
I have a daughter that has epilepsy.
Okay.
My daughter was on research, and we lived in one neighborhood, and she developed epilepsy. She was diagnosed with it. She started having Tonicclonic seizures. She was put on Treleftol, but then we moved, and I mean, she was having seizures, continuously, and so she even had the twitching of the leg and things like that. She was conscious. But then we moved to a different neighborhood, completely, 10 miles away or whatever, and she was still on Treleftol, but she wasn't having seizures, so we cut her back half dosage. Nothing. So then one day we finally, we took her off of it, we weaned her off of it, and she hasn't had seizures since. I wonder if
could you repeat the question?
Yeah, there's...
We got this thing going, I think. Yeah.
I'm sorry.
Okay, sorry, it's kind of long. I have a daughter who has epilepsy. It's not my 1P36 child, it's my oldest daughter. So she developed this when she was about 7 or 8 years old. She had a couple seizures at night, and we had her checked out. She has epilepsy, constant epileptic activity in the brain. So she was put on Treleftol, which is a seizure medication, and she was, and this is when we were living in our old house in an old neighborhood. She continued to have seizures, but when we moved to our new neighborhood, which is about 10 miles away, the seizures stopped. She was still on a Treleftol, which made her like a zombie, so we wanted to take her off of it. We weaned her off of it slowly. She didn't have any seizures, while we were living there. We took her off the medication, and she hasn't had a seizure. It's been almost 5 years. So I was wondering if environment has a connection with seizures.
Okay. I've heard some reports of environment having an effect upon seizure activity. But I think you bring up a real important point, and certainly one that I neglected. Sometimes epilepsy isn't forever. That there are people who actually will have epilepsy come into their life for a period of time, and then just as mysteriously as it arrived in their lives, it tends to leave. She's still seeing it? They're still seeing it on EEGs? And she's off her medication. Wow. That's a very rare case. You can still have the abnormal brain activity that sort of looks like that you might qualify as having epilepsy, and sometimes you just don't show any seizure activity. I've never had an EEG myself because I'm afraid of what my brain activity would look like. And I've had several opportunities. It's like, no, I'll pass. So it's possible she may still have some. She still may have some telltale signs without actually seeing seizure activity out of her. That's great, though. Those are those simple partial seizures that are, they're sensory in nature that you might see, okay, without that tonic-clonic event, okay? Other comments or questions?
Well, I do have one. Is it possible to look at a physical or electrical map of the brain and brain activity, or a combination of the both, to predict certain types of seizures or the possibility of a type of seizure?
What we do is our gold standard in the world of epilepsy is the EEG. Okay, and EEGs, by the particular area in which we're seeing the discharge, we can tell you what type of seizure activity that individual has. okay, whether it's partial or whether it's generalized. And you're thinking, well, is that such a big deal? It is a big deal because certain medications are prescribed for generalized seizures and others are prescribed for partial types of seizure activity. So it can vary greatly as to, so one of the keys to getting good treatment for a person who's having seizure activity is, number one, deciding what type of seizure the individual is having. Is it generalized in nature or is it partial in nature? Then parsing that down to find out exactly what specific seizure activity that is. What we use to do that is and UC's got a really nice one. They've got a epilepsy monitoring unit where they take the individual and they do it inpatient, where they hook them up to an EEG and videotape them for a period of 3 to maybe 5 days to actually observe seizure activity and get a good idea of what's taking place visually and also what's taking place within the person's brain. Okay? That way, usually we see better outcomes as far as treatment is concerned and control is concerned when we do that particular type of testing.
Gotcha. I guess I was thinking a little bit more, though, in terms of trying to predict certain types of seizure behavior, to be able to say, okay, you know, with the research that was presented earlier, for example, if we were to see certain manifestations of the condition we're all in here for that are more common than others, is there any way to take a look at that along with electrical activity to say they may not have this type of seizure activity now, but they may be prone to because the conditions exist, kind of like a tornado warning, right? The conditions exist that this may,
yeah,
and to begin looking forward, or at least making sure that we're aware of it.
There are usually what we do, because of the nature of anti-epileptic medications. Anti-epileptic medications are very, very powerful medications. Okay, and usually they have a variety of side effects associated with them. Usually we will wait until the individual actually begins to exhibit seizure activity before we prescribe those particular meds. Okay, that's our usual course. Of course, if you would have one seizure and then, you know, we would do EEGs and do a workup, and it would seem that you had maybe a greater than 60% chance of having repeat seizures, then we might prescribe after the first seizure. But usually we wait until your second seizure to prescribe at this point in time. So that first seizure, you know, physicians will tell you, is kind of for free. Mm-hmm. You know, the second one is when we become concerned and say, okay, we need to do something about this. Okay. I thought there was a hand, and yes, ma'am.
Yeah, my son has 5 different kinds of seizures. Right now he's being treated with valproic acid, which he takes levocarnitine to try to counteract the liver problems. He also takes clonazepam. Neither one of those seem to control the seizures. I haven't seen a difference. Last year he got a vagal nerve stimulator, which he's still having considerable seizures. Is there any point where we stop giving medications and back up and try to see, because he's already getting some elevated liver enzymes from the valproic, and I don't want to do more damage. So do we ever just cut off medication and start over again and see if we can find something that helps?
If you were going to do that, certainly you would want to do that in a hospital setting under very close supervision of his neurologist or epileptologist. You know, there's over 25, 30 different types of medications that are out to control seizure activity. So, you know, unless he's already run the menu, you know, there certainly are other options that are out there that might work in his particular case. There's also things that are happening that are in the pipeline right now as far as epilepsy is concerned. So, you know, my message to you is, yes, it might be frustrating, but certainly don't lose hope, because there are new things that are happening all the time as far as epilepsy is concerned. This is, if you had to have epilepsy at any particular point in time, this is the time that you want to have it, because there's so much stuff that is going on, amazing types of things, where there are other treatments and devices that are going to become available.
What are your thoughts on Charlotte's Web?
You know, I've been in the epilepsy world a long time, and I've seen all these, I've seen a lot of things that people say, this works, this works. You know, I've seen people who have taken their children to chiropractors and said, you know, maybe the chiropractor can do this. Maybe this particular thing. Let's try a really huge dose of B vitamins. You know, I've seen a lot of different things that have come out that have been the silver bullet. And I've seen and been disappointed a lot in those particular things. There are studies that are being done on this particular on this particular use of cannabinol, or I'm not sure what the CBD, I think it is. Okay, and they might yield some very, very promising results for certain individuals. The studies are being done right now. I'm hoping that it works. I've talked to some of the people who are using it at this point in time, and they are very, very happy with it. And for difficult to control seizures, it may very well be an answer for some folks. I don't think it's going to work for everybody. Okay.
I'll jump in just since the microphone is right here. We've been in and out of the seizure game for 10 years now. Lots of neurologists, lots of medications. Nothing really has completely stopped the seizures. They come and they go, and I don't have a lot of faith, I guess, in, you know, you'll do the 24-hour EEG and they'll say, oh, well, let's up the medication, and then you do another one 6 months later, oh, let's down the medication. And it just seems like the easiest job in the world to kind of sit there and guess on what the medication should be. But the question is, have you come across situations where it doesn't matter what the medication is, the seizures just aren't going to go away? And in those cases, you know, what are the best control methods to use other than that? And kind of related to that, you've got this 5-minute magic miracle. Like if it goes beyond 5 minutes, call the, you know, when her teachers see a seizure, they want to call the ambulance. And it doesn't help anybody to call an ambulance because they don't know what to do either. And then I just end up paying for the ambulance and going and get the kid from the hospital. So what's the point realistically where that, you know, is 5 minutes what we should tell them? Should we write that in an IEP? How do you address that?
You have to write that in the IEP. The first thing you do is you get that letter from your physician that indicates at what point in time they're supposed to administer emergency medication, if she has emergency medication. Also, at what time you want the ambulance called. Okay, what time do you want 911 called? Then you do have to put that in the IEP. Okay. And then usually what we also suggest that you put in the IEP is training for those teachers. The reason they are calling for emergency assistance as soon as they see seizure activity is because they're scared out of their wits. They don't know how to handle it, and they don't understand it. So I think part of the thing that you need to do is you need to provide them that education, and you can put that in the IEP process. I don't know where you're from, but certainly part of what we do at the Epilepsy Foundation is we go into the IEP with parents so that those particular things are present and are part of that legally binding document. So if once you get that in there, what happens is if they don't follow it, guess what? They're out of compliance. There are some kids that regardless of what you do, they tend to continue to have seizure activity. You know, I don't know if you're familiar. You probably are. The ketogenic diet. Okay, ketogenic. Maybe even a modified Atkins type of diet. That might be a way for you to go. You can use that in conjunction with medications, and might have. It's certainly a lot more tolerable for the individual who has to eat the stuff, and also for the parent who has to fix the stuff. Okay, so that might be another way for you to go. Okay, you know, I understand that sometimes it becomes a very, very frustrating thing, and in certain individuals there just aren't those easy answers. You know, you run through the medications 3 or 4 times, and as I said earlier, there are new things that are going to be on the market. Okay, and and sometimes it's the child growing that seems to have that seems to create a seizure control at some point in the individual's life. You know. Yeah, it's yeah. You know, I hope so. I hope so. I'm certainly not. I'm not buying any stock in it. You know, I'm not putting any money in those particular stocks. Okay, but I hope it works, and it may work for certain individuals, as with the medications that we have. Other comments or questions? Anything else? One further comment, okay? Make sure that if you're not having good control with seizure activity, make sure that you're seeing an epileptologist, a neurologist that specializes only in epilepsy. That's all they deal with. And there are certain centers that have epileptologists. Certainly, we have those here at UC.
Sorry if this question was asked before, since we were kind of like not able to be in. For something that we thought is a seizure activity, and he was taken to the hospital for, and went under the video EEG, and he was there for a whole week, did have an episode, and they're saying that it is absolutely not a seizure. Take him home. It's probably his 1P thing. You know, like he just dropped his head one day, stared off into space, fell over, and absolutely could not walk. You know, and I picked him up, and he would walk down the hall, fall into the wall. He was like very drunk, fell over. I picked him up, he threw up, and then passed out and slept for 3 hours. And it happens at home with his mother. And this went on for, I don't know, about maybe a week or 2 weeks straight. And they're telling us that it's not seizure activity. If it was, it would have shown up under the video EEG. Is it possible that it could be a seizure that's just not showing up?
The only time an EEG is a snapshot. It's a snapshot of your brainwave activity at that particular point in time. So if an individual isn't having seizure activity, or that particular event that you suspect is a seizure at that particular point when he or she is hooked up, they wouldn't be able to tell whether or not it's seizures or not.
Well, he did have one of the episodes in the hospital, and she is saying at the time that the button was pushed, it was absolutely no activity.
Okay, okay. You know, there's portable EEG equipment. I think it's called a Digitrace. That's one of the companies that makes it. Basically, you can do a 24-hour EEG at home. Okay, that may be a way of getting a better idea of whether or not it actually is seizure activity.
Can there be brainwave activity deeper in that the EEG cannot pick up? Because if I understand it correct, primarily they're looking at the outer cortex. They can't look further in on EEG. Is that correct? Correct. So there is potentially...
It would be possible.
Okay.
Okay. Here's the other thing. An EEG is only as good as the person who's reading it. There are certain folks who are really, really good at reading EEGs. There are other physicians that maybe aren't so great. Okay, okay. But that's something to consider too, okay?
I just want to speak up and make a comment on what she was just asking about. We had that same issue, and they were telling us that there was no seizures. So we actually had to videotape when he had an episode in order to get results and help. So that's what we had to do. We videotape.
And that's a very good suggestion. You know, and with everybody's got, almost everybody except me has a phone that you can actually videotape things with. You know, that most epileptologists or neurologists love that. They love to be able to see the event. If you can't see the event, write down a description of what took place during the event. That is invaluable as far as getting through the diagnostic process. Okay, very good. Thank you.
Just one more comment to this family up here. We had our epileptologist tell us that 10% of kids with seizures will not show it on an EEG. And so, yeah, I think they could have it and not be on an EEG. And then you have to decide if you're going to treat with medication or not.
Other comments or questions?
What's your favorite drug for complex viral seizures?
Let's see. There are a large variety. Okay, here's the shocker. Okay, you know we've got basically 3 generations of drugs. We've got these drugs that are really old that everybody says, oh gosh, you know these Dilantin and you know Tegretol and these particular medications, and then we've got a 2nd generation of medications, and then we've got a 3rd generation of medications. All the studies on those particular generations of medications, which ones work best with specific types of seizure activity, they're almost all as efficacious as the 1st generation. Okay, so the issue isn't so much what drug's going to control the seizure activity so well, it's what drug is going to give us the best quality of life as far as side effects are concerned. You know, if Johnny is on a particular medication and you give it to him and 40 minutes after he takes it, he goes nuts. Okay, guess what? That may not be the medication. So it isn't so much the drug itself, okay? They're all pretty good. It's which one's going to work for him, okay? And that becomes the frustrating process of this whole thing is, you know, trying to not only control the seizures, but also provide a good quality of life. You know, you know, there are medications. There are medications that go way back that basically they'll control your seizures, but of course you're not going to be awake to know whether you're having a seizure or not. So it's the quality of life issue that's the most important. Okay? Okay. Any other comments or questions? Oh, okay.
Just out of pure curiosity, could you explain on the molecular level what those medications are doing in the brain?
Okay, most of the medications that we have, okay, our older-based medications are either sodium channel blockers or potassium channel blockers. Okay, that's the way those particular things work, okay? And they do a good job of that. Now, what most of our newer medications, the ones that we're able to figure out how they work, because there's this group of medications that we have for epilepsy that you'll look at mechanism for action, and you'll think, and it's unknown. Okay, but the ones we do know that there's a particular substance in the brain called GABA. Okay, GABA actually it suppresses the synaptic activity. Okay, now we have medications that actually prevent the uptake of GABA to allow it to stay longer in your brain to suppress electrical activity. Okay, that's the way the three major ways that the medications work, okay? That's where they kind of got the name from. That was, you know, they pay somebody an incredible amount of money to figure out those names. I just wish it was me. Any other comments or questions? Finished if you are.
All right. Thank you very much.
No, thank you very much. Thank you for having me.